Hello, everyone, and welcome to today's MinMD Real Talk webinar, ED treatment options and relationship impacts. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenters. First up, we have Mark Goldberg. Mark is a clinical therapist who specializes in individual therapy, sex therapy, remarriage, co-parenting, couples therapy, anxiety, depression, and is located in Baltimore, Maryland. Next up, we have Dr. Patricia Heller. Dr. Heller is a board-certified urologist who specializes in erectile dysfunction, BPH, low testosterone, Peyronie's disease, bladder cancer, kidney stones, and is located in St. Louis, Missouri. Today, they're going to be covering the underlying causes of ED, medical treatment options, surgical treatment options, discuss how ED impacts relationships, conduct a short demo, and then hold a live Q&A to close out the webinar.
Good evening, everyone. Thanks so much for joining us. As Austin said, I'm Dr. Patricia Heller, and I'm very excited to be here to discuss erectile dysfunction. So I think it's a great place to start to talk about just the general ideas about ED, really what is the true definition of it, how common is it, and what are some of the most common causes of erectile dysfunction. Next slide, please. So defining ED, it's really the persistent inability to achieve and maintain an adequate erection for satisfactory sexual intercourse. So a lot of guys will notice that perhaps they have difficulty achieving an erection. Some guys are able to get a great erection, but just can't keep it long enough to complete penetrative intimacy or whatever intimacy they'd like to have with a partner. And so therefore, a lot of men come to me and other urologists like me who specialize in sexual medicine to talk about it, because approximately 1 in 5 men over the age of 20 go through this at some point in their lifetime. So it is so common. It can really feel isolating to men, though, to not really understand how common ED is. And again, over half of guys over 40 have some element of ED, and ED is a bit of a continuum. I find often it's not so much of a light switch phenomenon, but a progressive phenomenon that will impact men throughout the course of aging. And about 40 million men or so in the United States have ED. So again, very common, can feel very isolating, but it really is important to put these numbers out there for guys to understand it really is common, and there's lots of us here to help you through. Next slide. So lots of causes and conditions associated with ED, and I think this is probably one of the more important slides in terms of the nuts and bolts of ED, because as a urologist who treats men with sexual health concerns, I often am the one there diagnosing a patient with diabetes or cardiovascular disease, finding medications that he's on that could be causing side effects relating to his sexual function. So it is a huge thing to think about the underlying etiology of what could be going on in a man's body. It's one of the more common reasons a man seeks medical attention, because obviously sexual function, especially in younger men, is one of the things that is of paramount importance in their lives, and rightfully so. And it really does prompt them to get medical attention, which is very important to not only treat the problem, but to investigate what is underlying this problem. Obviously, there are other less common causes. Obviously, men who have prostate cancer or prostate surgery often end up with sexual health concerns. And there are other issues that are involved, of course, as well. But the part on the screen on the right-hand side is really important and a good schematic to help us all understand why erections are affected early on in these disease states. So the penile arteries are exquisitely small, and the arteries that feed the muscle of the heart that are involved in a heart attack are actually 2 to 3 times larger. So a man may first notice problems in the bedroom with sexual performance as a precursor to noticing chest pain or having a cardiac event, because the progressive changes in his vessels will start with the smallest ones and move on to the larger ones. Again, strokes and even claudication is the medical term for it, but pain in the legs with walking, these all can be markers that a man has some cardiovascular dysfunction and is having problems there that may early manifest as erectile dysfunction. So we do know that ED is now being looked at from a cardiovascular perspective as yet another marker of cardiovascular health. And I counsel my patients that, you know, any activities that you can do to improve your cardiovascular health, you're actually going to improve your penile health. So erectile dysfunction not only is a personal and interrelational and social thing that men deal with, but it can also be a serious health concern that really should be evaluated by someone who's a specialist in this arena. Next slide. So let's talk briefly about the erection process. So it's a really complicated system, and we'll just pare it down to the basics. Obviously, sexual stimulation causes nerve stimulation, and that's the first part of the cascade in the erectile process. Then the blood flows into the penis. The arteries that feed the penis, the arteries have muscle in the walls. They dilate to allow greater flow into the penis. That blood flow will then cause the corporal bodies, which are the 2 larger sections within the shaft of the penis, to expand. There are small little pockets in there, kind of like the inner portion of a sponge, that actually fill with blood to cause engorgement of the penis. And that in turn will pinch off the veins that are meant to take the blood away from the penis. And so those veins then will not drain for a certain period of time while the penis is erect. And again, this also ties back to what I said before about there being a bit of 2-part of an erectile dysfunction process, either the getting or the keeping. And so there can be nuances involved there that are important to talk about to your urologist to help figure out how to help you not only figure out what's underlying the ED if there is something there, but how to treat it best. Next, please. So ED medications, so how they work essentially is they are meant to allow greater blood flow to the penis. And that in most cases where they are successful will allow a man to have a proper erection that will be satisfactory to he and his partner and last long enough to complete intimacy. However, there are certain disease states like diabetes that often render a patient not as good of a candidate for these medicines, and often the medications fail a lot of men who have diabetes and ED just because of the inner workings of that complex process to achieve an erection. A lot of those parts of that are damaged by increased blood sugars. And so we find that a lot of men, unfortunately, don't respond as well to pills, which are obviously a very convenient and low risk way to start to treat ED. But another important takeaway from tonight that I hope everyone understands is that this is not where the road ends. There are a lot more treatment options, and every man with erectile dysfunction can have a satisfactory sex life. There's a way to get anyone there depending on his preferences. So if pills haven't worked for you, please seek other options that I'll explain here in a minute. Next, please. So this is an interesting slide. So in some communities within the United States right now, there's a boom in men's health clinics. And so they're branded in different ways: testosterone clinics, men's health clinics, wellness clinics. Often, unfortunately, a lot of those are not staffed by people like me who are true trained surgeons and medical specialists for men's health. And unfortunately, they don't always offer the most complete array of treatment options, the workup for why this is going on, and also don't necessarily give the patient the full honest scope of what actually will work in his particular scenario. So good places to start that I would endorse are general practice or family medicine doctors are often the ones who are starting a patient out with prescription medications, the oral pills, to start helping with ED. Oftentimes, if those are not satisfactory for the patient, whether due to side effects or inappropriate or inadequate response to the medicines, they will send them on to someone else who is a urologist. So a urologist is a doctor who treats a whole host of medical conditions from the kidneys, prostate, bladder, and sexual health. Their training varies though. And so some may not have the full acumen of all the treatment options at their disposal. Someone like me, an ED specialist or a prosthetic urologist is sometimes what we're called, is trained in treating even the most complex situations and can offer a patient all the options. And to me, people like me in the medical community as prosthetic and ED specialists are the best patient or people to treat patients with erectile dysfunction that is needing help beyond the pills. Next, please. So when we talk about treatment options, I'll go through these in general. Obviously, I've spent a moment or two on oral medications. From there, I always tell my patients, you know, that's obviously the nicest place to start, the gentlest intro to the whole thing. However, we do have to up the ante if those things aren't working, and each one gets a bit progressively more invasive. These, although, are on par with one another, meaning you don't have to go through a stepwise process and have a poor experience with each one of these things in order to be a candidate for the next option. So really, any and all of these are on the table for any man who has ED. Next. And this one we'll turn over to Mark.
Thank you, Dr. Heller. So we're going to talk a little bit now about communicating with your partner about ED. Generally, I encourage the people that I work with and people in general that conversations about sex and intimacy should not start when a sexual dysfunction or a problem has arrived for a couple, and people should be talking about these topics earlier. However, many couples find that they only begin communicating about sex when it comes to ED. One of the common questions that I get from people that I work with is, why do I have to communicate about this? Doesn't my partner know? The answer is not necessarily. Men oftentimes are initiators in a sexual relationship, and when they experience ED, they can begin to just avoid initiating. So instead of having a number of encounters where erections have become unreliable over an extended period of time, there are many men who actually will avoid, and their partners will be under the impression that they have just lost interest or lost sexual esteem without knowing that there is actual erectile dysfunction going on. So what exactly should people be talking about? So for the man who's experiencing ED, talking about his distress about the condition, feeling less masculine, shame, these are conversations that could be helpful, as well as being able to have conversations about what can actually be done to remedy and rectify the erectile dysfunction, both from a partnered perspective and from a medical perspective. When it comes to the partner, for a man who's experiencing ED to be able to check in about what the partner's experience is, including their distress, their insecurity, and what this means for them. Why have these conversations? So I see two primary reasons why these conversations are important. One, men's worst fears about their partner's thoughts and feelings are generally not accurate. That misconception can create a tremendous amount of anxiety, which ends up compounding and maintaining the sexual dysfunction. This is particularly true in situations where men are experiencing situational erectile dysfunction that is far more pronounced with a partner. The second reason is that a partner can play an important role in any adjustments that are going to have to be made in order to accommodate treatment for erectile dysfunction. Now, erection challenges are also an opportunity to engage in other forms of physical contact. In these situations, couples sometimes find that activities that they previously not engaged in actually leads to better outcomes for one or both partners, and they really were forced into that by necessity. Other couples will also find that men who are experiencing erectile dysfunction do become more attentive to their partners in non-sexual areas as well. So there are some benefits that also can come from this, and a lot of that comes from these conversations. There are 3 ED conversations that I recommend that any man who's experiencing to have with their partner. The first is that a penis was not and never will be a thermometer of how you feel about your partner. Really important to get that message across as clearly as you can. Number 2 is to ask about what the role of an erection has been and needs to be in sexual encounters moving forward. And number 3 is to ask about how your partner feels about you. Do they look at you any differently? Next slide.
Thanks, Mark. All those great points. I also encourage my patients to bring their spouse or partner with them to an appointment with me so we can all discuss the mechanisms of erectile dysfunction, because I think when it's framed a little bit more as a medical problem and not just a relational problem, it does definitely help smooth the waters and opens up the dialogues for conversation and in a less animosity-filled way. So we've already talked a bit about oral medications, so I think we'll stay brief here. There are several different types. Lots of men have heard of these. Sildenafil and tadalafil, or Cialis and Viagra, are the very common medicines that most men are prescribed. Thankfully, now they've gone generic and are affordable. They're taken in an interval of time before anticipated sexual activity. Again, as I said, it increases blood flow to the penis. It does require sexual stimulation, so it is not meant to provide a spontaneous erection of the patient without engagement with some sort of sexual stimulation. And effective in up to 75% of men of ED. I would put an asterisk there, as I mentioned before, of men with diabetes, that number is definitely lower. They're not recommended if you take certain other medications. Alpha blockers, we sometimes can separate those in a temporal way and have a patient not take those 2 medicines at the same time, avoiding some low blood pressure type symptoms. So that's something to navigate with your prescribing doctor. If you do already have low blood pressure, obviously these are going to make that worse and may have side effects there. Nitrate medications is really the major contraindication of these drugs. If a patient takes nitrates on a regular basis or has to use an under the tongue tablet for chest pain from time to time, we are a bit more hesitant to prescribe these medicines because there can be a catastrophic change in blood pressure due to that combination of medicines. Some men, in addition, as I said before, to having an inadequate response, have side effects that are just intolerable and often not very conducive to intimacy, such as facial flushing, nasal congestion. Blurred vision is a really major one that should be and never ever take this type of medicine again. Side effects, so if a patient has changes in visual acuity or color, he should never take any of these types of medicines again. Back pain, muscle pain are also very common. Stomach upset, and pretty significant headaches are the biggest thing that my patients describe to me. Next slide, please. So intraurethral gels and also intraurethral suppositories are another option. Unfortunately, I find that most patients prefer other modalities than these, primarily because of a sensation of urethral burning or pain at the tip of the penis inside the urinary tube is quite pronounced with this medication. And that too also is not as conducive to intimacy when there's pain involved. It is a non-injection administration of the medicine, so even though there is a syringe, there's no needle. So this medicine is gently inserted into the tip of the penis where the hole is, where the urine comes out. It does work pretty quickly, but often is a difficult one to have a standalone success with if just using this medication alone. I found that lots of patients use this in conjunction with other things, such as vacuum pumps or even oral medications, to try to enhance the benefit of simply inadequate response to one or the other. But again, I would say I have a very small patient population, if any, who find these to be satisfactory, but it is an option. Next slide. So intracavernosal injection therapy is quite a popular option. And later in tonight's webinar, I'll give you a general idea of how this is actually performed, but these pictures do quite depict it well. It's a simple injection of medicine. It's a very small needle where a patient will inject his penis on the sides of the penis, one side for each event that he'd like to have an erection. It works pretty well, and it is a good option for men who've had prostate surgery where the nerves are no longer functioning. If they've had prostate removed for cancer, these types of administrations of medicines do work well for patients like that, and often in patients with diabetes as well. Some patients find them to be painful or obviously having a needle near their penis. Some patients just don't find that to be satisfactory, which again is completely understandable. So it's nice to have a lot of different options because there's certainly not a one-size-fits-all approach here. It can cause some scarring within the tissues inside the penis and the corporal bodies, which is the place where you want the medicine to go. The only concern with that is that it can cause ultimately a curvature of the penis, or also make a penile implant procedure a little bit more difficult to perform in the future should a patient want that. But with just a short-term use, those side effects typically aren't encountered. Patients who are on blood thinners often cannot tolerate this type of medication because of the bruising involved in the injection site. And so I do have a lot of patients who at least spend a little while doing this type of modality before they move on to a more complete definitive treatment. And so I think it is a really good viable option for lots of patients. It is a bit limiting, however, because you do have to keep this medicine refrigerated. So if you're traveling or doing activities outside of a home base where you have access to a refrigerator, that does make it a little bit limiting, but it can be worked around. Next slide, please. And this is another great spot for Mark to give us some insight here.
Okay, so we're going to focus on this slide in particular around communication and challenges that a couple faces when it comes to ICI. So to get started, let's just talk a little bit about what a sexual script is. So anybody who has been, or almost anybody I should say, who has been in a long-term sexual relationship probably has developed a sexual script or maybe a couple versions of sexual scripts with their partners. Most often, these are unspoken. So as a basic example of a sexual script is a couple knows that when a partner puts on a certain item, that indicates that they want to engage in sexual activity, and then touching follows a pretty set routine. Some couples have it down even to amount of time. So they will rotate through various forms of sexual and intimate touch for 2 or 3 minutes, and then oftentimes things will ultimately culminate in penetrative sex. Now, most couples, most individuals do not closely look at or even think about their sexual script until something forces a change in that script. Now, when it comes to ICI or intracavernosal injections, it's important to make a big distinction here, at least from my perspective, that medications like the PDE5 inhibitors are erection promoters in the sense that they still rely on the role of sexual desire and feelings of arousal in order to make them work. With ICI, and Dr. Heller, you can please weigh in on this, the reliance on the sexual feelings of arousal is a lot less, if sometimes not necessary at all. Is that correct?
I would agree. Yes, this is a higher dose of medication delivered directly to the target tissues. So there's less need for that mental aspect to get the nerve and stimulation going in the penis. And so I think this definitely is more of a local acting drug that can bypass a lot of the sort of social emotional components to physiologic erections.
Correct. Okay, so given that ICI is more of an inducer that does not require that same level of arousal or emotional connection and whatnot, that is already a factor that can potentially change the script. The obvious other factor here that we're going to touch on in just a moment is the process of getting the injection into the penis in the midst of sexual activity is very different than taking an oral medication. I also want to just recognize one distinction that I'm not going to get too deep into is that men tend to fall into 2 categories when it comes to ICI. Either they are post some prostate procedure or prostatectomy in which they can rapidly go from sometimes not needing any medication to using injections, which can be kind of sudden. And there are other men who progress over time to maybe they saw some efficacy with some of the other treatments, and over time they saw diminishing results and have now over time transitioned to using ICI to improve erections, which is going to create a little bit of a different dynamic when it comes to talking about addressing sexual scripts. Now, when we look at the steps on the slide, the injection is done 5 to 15 minutes before sexual activity, which already for a lot of people, we're talking about their script, have to figure out where does that fit in to a process that probably once upon a time did not rely on a 5 to 15-minute window. On top of that, a man has to fetch a vial from a refrigerator, he has to clean the vial top and the injection site, draw the medication, pressure injection site for at least 1 minute, and then inject, and then I think you have to wait for a response to form. So if your sexual script up until now has largely relied on getting into bed and one person just starts rubbing the other person's shoulder and things progress from there, having a 5 to 15-minute window where you're not expecting to have an erection or a response and having to pause and get up can be very disruptive to the process. So there are two basic ways that men are going to go about doing this. One is they're going to take care of this process before engaging in any sexual activity, before initiating. So what this does is twofold. So it creates a challenge because this can often disrupt a pre-existing foreplay routine where the partner has previously been involved in helping to elicit or facilitate that erection. And the second part is that without that warm-up period, a man may find that he is actually injecting the ICI before he has the arousal and desire that he's regularly accustomed to, which again can create some challenges and needs to be considered in adjusting sexual scripts. The other option is for a couple to try to incorporate this into their sexual routine in a way that is minimally disruptive to the erotic flow. Because I think at the core of all of this is going to be trying to maintain an erotic flow throughout this experience with the injection. So I can share with you just some of the solutions that I've heard that couples, that I've heard from people that I've worked with that have been effective. So if you have a partner who is medically savvy, and is able to perform that injection for you and is comfortable to do that, there are couples that have found different ways to incorporate that into their sexual repertoire and into the play. Obviously, it takes some forethought in terms of making sure that the needle is ready and some kind of adjustments for that. There are many partners, though, who are uncomfortable even seeing a needle in front of them, let alone being a part of the process. So one of the ways that couples manage that is that they incorporate some self-stimulation with the encouragement of the partner who's struggling with ED and using ICI, that during that time period they can encourage and incorporate elements of self-stimulation and self-touch into that process while waiting for the man to exit and inject and then return and re-engage with that process. Now, it could be a very small window because you don't need an erection necessarily to be active and supportive in your partner's pleasure, but you would have to have a window to possibly exit or at least not do this in front of your partner who's uncomfortable with the needle. Now, there are partners who are just uncomfortable with the notion of self-stimulation and self-touch. And what I have heard from other people in these situations is that they do find a way to try to maintain some kind of contact, either verbal or physical, while engaging in the injection process with the partner not facing them and not looking, and trying again. The whole goal of all of this, though, is to maintain some erotic bond during the injection process and not losing the flow of the sexual script. Next slide.
All right, so just to touch briefly on a few things here, more treatment options. So vacuum erection devices. So these can be a bit cumbersome, and I don't find a lot of patients like these long term. Essentially, it's a mechanical way to draw blood into the penis when that normal mechanism isn't working as properly as it should. Once the blood is drawn into the penis, whether it's a manual or a battery operated pump, the patient then applies a ring to the base of the penis to keep the blood there. As I said, two-step process, blood goes in and blood has to stay. I think the main complaint I hear from patients about this is just obviously the cumbersome nature of the device itself, and also that the penis can feel cooler to touch and just not look aesthetically as it did before. Again, it can be something that people incorporate into additions to other modalities like oral medications or intraurethral medications, but as a standalone device, I don't find a lot of patients prefer this to be their only treatment. Next slide. We do encourage the use of a penile external pump for rehabilitation to help with penile length recovery, especially after prostatectomy for prostate cancer. And sometimes when patients aren't having as many frequent erections. So I always tell men, you know, if the penis isn't stretching and relaxing like it did when you're in your 20s, certainly loss of penile length is part of the aging process of the penis. The stretchy tissues inside sometimes get a bit more stiff or fibrotic. And naturally, a loss of length there is certainly to be expected as men age. And so this can help a man regain a small amount, not all of it, but it can be helpful in certain patient scenarios. Next slide. So penile implant is really the only way to completely give control over erection function back to the patient so that he's able to have an on-demand erection that is 10 out of 10 quality and lasts as long as he wants it to, because certainly those are the key factors for a man to feel successful and confident in order to feel good about engaging with a partner in intimacy. And so this is something I do a lot of in my practice as a prosthetic urologist. I think it's important to seek out a surgeon who has a breadth of experience in all different types of penile implants and all sorts of permutations of particular anatomical things, like if a patient has Peyronie's disease or limitations to manual dexterity. Those are things that the surgeon needs to take into account. And I think surgeon selection, this is a critical thing. So I would encourage men, if they're considering this, to seek out a person who does a high volume of prosthetic implants. So essentially the nuts and bolts of this is there are 2 silicone cylinders within the penile tissues that are installed through a tiny opening in the skin. These vessels act to hold sterile saline or saltwater solution that's hidden away up under the abdominal muscles in a small reservoir when the penis is not meant to be erect. And the penis looks very natural. All of this is self-contained within inside the body. And if a man is unclothed, no one would know that he has this implant there unless he told them. And the saltwater mechanism is nice because the patient is under complete control of when the penis is erect and when it is back to its natural looking soft state. He simply uses a pump in the scrotum to deliver the fluid into the chambers in the penis to induce an erection, and it is on demand. It travels with him. There are no caveats to it in terms of how many uses you can have. There's no refrigerations or refills of medicines. And frankly, a lot of my patients come to the conclusion that they would rather have a definitive cure than mess around with things that may or may not work, because certainly socially, psychologically, and relationally, if they're not able to be successful time and time again, that can really put an impact and a strain on their relationship. Next slide. So this is the demonstration video of the similar cartoon picture to just allow an insight into how that function I had previously described works. So I'll kind of walk through. So again, this is all an internally contained device. The patient is taught with time and recovery after surgery how to operate this pump, which is a small bulb in the scrotum, to deliver the fluid from that reservoir into the penis. And once he's decided that he no longer desires to have an erection, there is a deflation button that the patient will press to allow the valve to open and the fluid to return to the concealed spot up underneath the belly muscles that never is seen. You know, even if a patient has his shirt off, no one can see that reservoir that's up underneath the abdominal muscles. So it's a very discreet, definitive cure for erectile dysfunction. Certainly in any surgical procedure, I'm always happy to discuss the pros and cons of these procedures with patients. You know, most insurance do cover these types of procedures, and certainly we work hard to make sure that that's the case before we have a patient engaging in a surgical procedure. The mechanism by placing this device does not allow for natural or spontaneous erections to happen again. But again, the patients who are seeking this type of treatment have none of that to begin with, so there's really no loss there. There can be mechanical failures like any device, and sometimes we have to go back in and revise things, but that's rare. And certainly we want to make sure that we don't have an infection, and there are processes involved. Each surgeon is different, but I have a very tight control over the process before surgery, during, and after surgery that I think really has optimized my patients' outcomes, not only for the implant, but also for avoiding infections related to the implant. And there are certain patients, such as patients with diabetes or skin lesions, that clearly have a higher risk of infection, but I'm always careful to counsel those patients with regard to their personal situation. Next slide, please. And here's more from Mark on sexual script changes for penile implant.
So penile implants are certainly remarkable devices. Now that we know what a sexual script is, the adjustments to the sexual script when it comes to a penile implant are fundamentally different than when we're talking about ICI, in the sense that these many men who have implants go from very unreliable erections and solutions that do have a bit of a time gap between injection or ingestion until they get that erection, to a very quick, very reliable erection. I believe that it's something in the order of like 15 pumps, and a full hard erection is able to be used. So in many instances, partnered sexual activity with an erection has been very limited or non-existent for these couples, and many of them have adjusted to this reality that erections are going to be unreliable, or they've adjusted their script to ICIs, and now they have to go through another adjustment. It can be awkward and challenging to restart a sexual relationship, especially if there have been no other solutions that have been effective and a man has been waiting for some time to get an implant. And if couples have not been speaking about the impact on their sexual relationship, it's not uncommon for couples to not know where to start. So sometimes a man has a very powerful and quick way to get an erection, but the couple just does not know how to navigate some of these new changes. So some of the considerations with implants when it comes to sexual script is, again, like the ICI, a man's desire is not needed with the implant. So because you can get an erection in generally under 30 seconds, how is desire being incorporated into the process? There's a lot more that goes into partnered sexual activity than just the erection. Your partner's probably going to want to feel that you want to be there, that there's desire and whatnot. And the natural process by which that is incorporated into an erection with a PDE5 inhibitor, or an erection in a younger person who doesn't rely on anything, that part is not necessary to create the erection, but may very well be necessary for the partner and for the relationship. Another question to consider when it comes to sexual scripts is, when is it enough? With IPP, I think, unlike many of the other treatments that are out there, post-ejaculation, a man does not lose his erection because it has been pumped up by the implant. So this has to become a conversation between the man and his partner if they want to continue sexual activity post-ejaculation, or if post-ejaculation has historically been the end of sexual activity, is that the way that they want to maintain things? Now, a partner may expect a slower warm-up period, which used to be how things worked, either with ICI or with waiting for oral medication, or I would say even with men who at a earlier stage in life, even in their 20s and 30s, it would take some time for both partners to get warmed up. So it's important to be sensitive that a partner may also feel guilty that they're holding up the process, because the man with the implant is basically ready to go, at least from a physiological standpoint, almost from the get-go. So it's important that men with implants be sensitive to that. Lastly, what I would just mention as well is that for couples who remain sexually active in the process leading up to, and certainly in that waiting period for a penile implant, have oftentimes engaged in all sorts of alternative forms of sexuality that could be very much to the benefit of the partner. It's not uncommon that when there is now a effective and reliable solution For the erections, the partner may want to continue with some of those other activities, where the man with the implant may have looked at it as just a temporary patch until that implant is in place. So it's important to also just be sensitive to what the impact has been on the partner in the time being, and that they may not want to give up all of the components that to you, as the man with the implant, seem to be just a temporary patch or solution. Next slide.
So this is an important slide just to conclude to say there are solutions. Prosthetic urology is an important part of helping men gain these solutions to erectile dysfunction. edcure.org is a great place to find someone in your local area who is qualified to help you walk through the process and determine if a penile implant is right for you. Yeah, so quickly, I just want to kind of show everyone what it's like to do an injection. I have a penis model here. So essentially what is required is some sterile alcohol wipes that are used to cleanse not only the penis, but the vial of medicine that's used to be injected. So what we also need is a very small syringe with a needle that is kind of hard to see. It's so tiny, but it is a very reasonable size needle for especially even men who are very scared of needles. So first off, the vial of medicine comes like this. I clean with an alcohol swab the top of the vial just to make sure there aren't any bacteria there before I begin to drop the medication. Patient's doctor will recommend a dosing based on his response to the injection medicine in the office. So we just invert this and pull back the intended amount of medication. And then on the penis, so important to think about where to inject on the penis. So on the top of the penis is where the nerves and vessels are, and that is not the right place to inject, nor is the underside of the penis where the urinary tube or the urethra runs. So essentially when looking at the penis, on the sides, in the 1 and 3 o'clock position is where injection should occur. And I always counsel my patients that it's important to make sure that you alternate sides for injection to decrease the risk of fibrosis. So here what we would do is prepare the penis and the penile skin with a alcohol prep pad. We would look on the penile skin. Obviously on this model there aren't any veins visible, but on most men you can see superficial veins, and I would avoid injecting in those areas. Then we would take the needle in an approximately 90-degree fashion and insert it completely into the corporal body, inject the medication in by depressing the plunger. We would remove the needle and apply pressure with either a gauze, or you can even use the alcohol pad again in order to stop bleeding from that spot, especially important in men who are on anticoagulation medication. And that's simply all that's needed in terms of performing a penile injection for intracavernosal or ICI. Now moving on to the penile implant. So quickly, in the interest of time, so we can get to more questions. This is a model of the Boston Scientific penile implant. This is a silicone penis with simulated testicles here. On the bottom, let me raise this up so everyone can see. There are testicles here and a pump in the scrotum. So essentially what we would teach the patient to do after a penile implant is learn how to pump the pump, which is here in the scrotum. And we would show the patient and or his partner, if he would like to involve his partner in the process, on how to squeeze the pump, which is then moving fluid from a reservoir, which is simulated back here, which would be that salt water containing reservoir up underneath the belly muscles, completely hidden from view. And every patient's anatomy is different, so the size of the implant is different. It's customized to the patient. We always try to give the patient the maximal size implant that his body will allow. So the number of pumps required to inflate the implant can vary just based on the patient's anatomy. But as you can see here, while we're talking, within just a few seconds, we've taken the penis from a flaccid state to a fully erect state with good rigidity in the penile shaft skin. Once the patient and his partner are satisfied with the intimacy, the patient then will grasp the deflation button and hold that, which allows the valve to open and moves the fluid back into the reservoir. This process can be expedited by the patient also with his opposite hand grasping the shaft of the penis and applying gentle pressure to encourage the fluid to move against gravity back up into the reservoir in the abdomen. But all in all, as you can see, even though this is a simulated anatomy figure, the penis with the implant inside, really without anyone knowing it's there, it's very well concealed and it looks very natural. And that's all I have in the demo. I think we can move into the Q&A session.
Absolutely. Thanks for putting on that demo. Just so everyone knows, we got a bunch of questions for the Q&A session, so I appreciate everyone who sent those questions in. We got a little under 15 minutes, so we'll get through as many as we can, but we'll kind of alternate between some of the relationship questions that we got, which were many, and then some of the ED specific and treatment specific questions that we got. So first up here, I'm 66 years old. My prostate was removed when I was 44. How do I make my wife understand the psychological stress a man endures because of 22 years of dealing with ED? That one might be a good Mark question.
Okay, can you just repeat back the details? I want to be as precise as I can be. I'm sorry.
Absolutely. All right, so this person says, I'm 66 years old. My prostate was removed when I was 44. How do I make my wife understand the psychological stress a man endures because of 22 years of dealing with ED?
Okay, I mean it's a heavy question. There's no doubt it's a heavy question. Number one, I would say if you have not been successful up until now, I'd strongly encourage you to work with a therapist. That's number one. It's a very difficult experience for any man to go through ED for any period of time, but certainly over 22 years. There's a lot of distress packed into that. It may be very difficult to successfully articulate that on your own. I think working with a professional would make the most sense. I don't know much about what the partner's experience of all of that has been. I don't know if she is receptive to those kind of conversations. I don't know if she's internalized this over those years. But I think working with a couples therapist to work through and try to get that message across would be the best bet.
Absolutely. Just so you know, Mark, we're coming with nothing but heavy questions on the relationship side, so be prepared.
It's okay.
Okay. All right. Next question is going to be around injection therapy. So I tried injection therapy with minimal results. What percentage of men does injection therapy just not work for?
It's kind of difficult to answer without understanding the patient's medical background and the etiology of his ED. There are different formulations, though, for intracavernosal injections, so it's not a one-size-fits-all modality either. There are a variety of different strengths. There are typically 2 to 3 or 4 even medications that can be compounded in order to create the proper injection therapy for the patient. So I would say if the patient has not tried any other types of injection therapy or different compounding recipes or even different dosing strategies, I would say that that's something that he should explore and see if there's another answer there. But there are some patients, unfortunately, due to the severity and the duration of their ED, that injection therapy may provide a partial erection but is not able to achieve a complete erection satisfactory to the patient, his partner. And then at that point, I would recommend a patient in that situation seek out the evaluation of a prosthetic urologist.
Absolutely. Okay, next question here kind of goes back to when you were pointing out the size of the needle for the injection therapy. So it could be a good question for either one of you to answer here, but here's the question. How do I get over my fear of injections and needles?
I guess I'll dive in. So I think there's a number of stages of fear when it comes to injection with needles. There was a recent article, it's a little bit anecdotal, but it was a study published in a journal that did indicate that when men have an initial fear of injection, they overestimate that, in particular when it comes to ICI needles, by a tremendous amount. So if we're talking about fear at the initial onset, perhaps doing that with a medical professional initially, and getting over the actual fear of pain. If there's a broader fear of needles, again, then we're looking at something that's probably more along the lines of a phobia, specifically if it's not necessarily driven by a fear of pain. And again, I don't want to answer every question here with go to a therapist, but I do think that would be something that would have to be worked through as a separate specific fear of needles.
And just to dovetail off what Mark said, I think I do find a lot of patients a little bit hesitant about trying intracavernosal injections, and I ask them if they're open to it to come to my office for a trial dose, which I always do with my patients and their partner if willing to join them in that appointment. And I do show them the size of the needle. I show them the process. They get to experience firsthand with me there along their side to know whether or not the pain that they endure for it is tolerable. And I do think, though, that if a patient has a successful event with that initial injection, that perhaps they understand then the compromise that may be made if their fear of needles is not, or fear of the pain from the injections is not so great, that they would avoid having the positive outcome that they see with it. I think that can change the paradigm for the patient in and of itself. And sometimes patients just can't get over that and don't want to even attempt it. And from my perspective, I am respectful of that. Sometimes that can be the end of their journey, though, unfortunately. And then I would say certainly counseling about that might be a way to go. But some patients simply say, I'd rather have a more definitive treatment and move on to a penile implant, which also I don't think is a wrong solution.
Absolutely. Okay, moving on to the next question here. This one's about implants. It's kind of a different angle here. Haven't heard this one before. Is an implant possible if a man has had a vasectomy?
100% yes. Has nothing to do with successfulness of a penile implant.
All right. Perfect. Next question here is on the relationship side. How do I navigate the dating world being a recent bachelor with ED?
So again, I think Dr. Heller has also made this point. It's very tricky to answer these questions in a way that's going to be helpful. A lot of this is really in the details. I don't know if you are a bachelor at the age of 34 and you have ED that's partner driven and somewhat psychogenic, or if you are a bachelor at 68 and considering an implant. So it's very difficult to answer these questions. What I will say, broad strokes, is that many men who have exited a relationship, either by loss of a spouse or post-divorce, do experience an anxiety engaging in new relationships and being on the dating scene. And I think addressing that anxiety in and of itself and adjusting to being back in, for many men, what is a totally revolutionized dating scene when it comes to use of technology and apps. I think, again, working with a counselor to address some of that anxiety could be helpful in and of itself. I also recognize that there is a pronounced challenge when dating of if and when to broach this topic with a brand new partner. Is it going to scare them off, or is this going to help kind of advance or build the relationship? But again, I think these are the questions that need to be assessed on a case-by-case basis.
And I also, just to add a little bit there too, I also find that a lot of patients would like to have some level of confidence that maybe they test drive in a more personal moment at home without a partner, in order to have the confidence that they will be able to perform if given the opportunity. So it kind of becomes a bit of a chicken and egg thing there too. And in younger patients who are struggling in that area, I do find that a low dose Cialis can often give them more spontaneous erections, less timed pressure for application of some kind of medication or treatment in the moment, which in an early dating scenario can boost their confidence and get that a little bit out of their mind. So I do find that as a general idea can be really helpful for men who are on the younger age and have mild to moderate ED. That can boost their confidence and get them over the hump there, so to speak.
Okay. Got a question here around diet. Is there a direct relationship with our diet and ED?
100%. Anything good for your heart is good for your penis, as I said before. We know that cardiovascular risk factors, including uncontrolled lipids like high cholesterol and those types of things, obesity, low testosterone related to obesity or onto itself also can play a role. So men who have good exercise habits, don't smoke, don't use recreational drugs, and eat a healthy diet with a normal body weight and work on gaining muscle mass, have healthier penises and better erections.
All right, next question here is a ton of information, so hopefully we've got enough here to give a full answer. I turned 50 and got less consistent in the bedroom, so I got a prescription for tadalafil 5 milligrams from my PCP. It worked well. I still take one on date nights. All is well. Here's the thing. I can get and sustain an erection while masturbating without the pill. Is my prior inconsistency fixed because of tadalafil, or is the tadalafil giving me the confidence to perform?
I would say probably both.
I would agree.
Okay, short and simple. I like it. All right, next question here. Can a person become mentally or physically dependent on ED medication?
Tricky to know. What I do is oftentimes if I suspect that there's a psychological confidence type component and the patient's working with a therapist and also working on physical things to help with his erections, I will attempt to titrate him off the medication to see how we do. Sometimes, again, there can be such a psychological component that can be solved in a way with a physical boost that it sometimes heals itself that way. And if I'm able to wean a patient off medication successfully, then we have our answer. Sometimes though, and we are not able to, and I'd be curious about Mark's thoughts on this as well.
So I don't know much about a physical dependency on medications like PDE5 inhibitors. I certainly have seen men who do develop we'll call it an element of a psychological dependency. I don't, as a therapist, I don't take tremendous issue with that. In other words, if it's a solution that seems to be working and effective, I will happily in conjunction with the urologist that I work with, we can work to try to titrate the person off the medication over time. But if things begin to slip, a lot of times in my experience doing this work, it's just not worth it. If the solution is working and it's not creating any medical issues or challenges. So while I think that there may be an element of psychological dependence, I'm not sure in the scheme of things and where the experience of erectile dysfunction can really cascade in a negative way for men. I'm not sure if it's always worthwhile getting too caught in this calculation, as opposed to just working with the solution that you have. And if you've tried multiple times to come off and it's not going, then I would just encourage men to stick with it.
All right. Next question here is a two-parter about implants. So first part of this question is, how long does the implant surgery take? Is it outpatient? And the second part of that is, health is important to me. How soon can I exercise after getting the implant surgery?
So each surgeon has their own protocols. I can speak to mine. So the penile implant surgery takes about an hour, a little over, depending on the patient's anatomy and if there are any confounding factors like Peyronie's disease in addition to erectile dysfunction, or if a patient has incontinence after a radical prostatectomy. Those add-on procedures definitely take a little bit longer. But I would say in my hands, a little over an hour is about a typical surgery time. Every implanter, though, is different based on their level of experience and the team that they have in their operating room to help them be successful for the patient. In terms of inpatient versus outpatient, in my practice, I do have patients stay overnight in the hospital to receive IV antibiotics, and also I have drains in the patient after surgery and a Foley catheter, which I like to have removed prior to his discharge home. So I do keep him overnight. However, from an insurance perspective, it is considered an outpatient surgery with an extended recovery. So that's favorable for the patient in terms of insurance benefits. There are some providers who do these surgeries strictly as an outpatient. However, the patient does have to return to the office within the next day or so to have a catheter or drain removed. So I find it's just nicer for the patient to sort of take a rest overnight, have some ice on his scrotum, and have pain medication and IV antibiotics going, and nurses tending to his drains so he doesn't have to manage those at home. And then in terms of follow-up with activities, usually within the 2 to 4 week period is the most significant recovery time for the patient. I ask my patients to refrain from strong physical lifting or activities over 15 pounds of lifting up to 6 weeks postoperatively because of the abdominal incision that I make to place the reservoir. If we have them do exertional activity too soon, there is the potential for a herniation of that. I've not seen it, but most of my patients are very compliant with my instructions, which are quite thorough. And from a lot of experience, I've seen what does and doesn't work. And so I think I have a good framework set up for a patient to have success. And so a patient should take that into consideration when considering an implant. Perhaps there's a time of year that's more convenient for him to take those times off to recover properly, because it is an investment from a physical, mental, and financial perspective. And you might as well do all the things to optimize your outcome. Part of that's me, but part of that's the patient. And I really do my best to impart that to the patient, that there is some downtime required after the surgery. But usually a patient is back to sexual intimacy by 4 to 6 weeks after the surgery, which is a pretty quick timeline, I would say, if it's been quite a long time since he's been able to do that on his own.
All right, we're coming up to the end of the event here, so we'll ask 2 more questions and we'll wrap it up here. So next question here looks like it could be answered by both of you, so I'll start it off here. My ED has caused me to lose my libido. How do I manage my lack of desire but yet satisfy my wife? And then the second part of that is there anything I can take to get my libido back?
I'll take the first part, Dr. Heller. I think the
Sure.
second part is going to be more.
Sure.
So there definitely is a chicken egg when it comes to erectile dysfunction, or I think any sexual dysfunction and loss of libido. When I'm working with a man who's experiencing both, I want to know what order they happened in, because it kind of gives me an indicator of what's driving what. When it comes to pleasing a partner, so I don't want to oversimplify this. Obviously, there are things that can be done between you and your partner that do not require an erection. So number one, I would encourage you to think about that. At the same time, I don't want to oversimplify things, because I recognize that without libido, I think many people, in particular men, will experience a lot of vulnerability engaging in sexual activity without feeling that internal drive, that sex drive within them. So I recognize that these activities are super vulnerable to be engaged with, but there are a number of things that can be done to facilitate partner pleasure. If those are too vulnerable and it feels comfortable enough between you and your partner, being present while your partner engages in some form of stimulation, either if it's a female partner and you want to incorporate a vibrator, and just being able to hold that, so it's a form of engagement and you are present with that experience, that also may be a solution if you are not experiencing a tremendous amount of libido and it feels overly vulnerable to engage in a one-sided sexual activity where you are pleasuring your partner alone.
And I would echo Mark's statements there. I do find the chicken and egg phenomenon is significant. I often use a baseball analogy with my patients. If you know you're going to strike out, every time you go up to bat, you're going to stay in the dugout and you're not going to want to initiate intimacy. And I think sometimes men have a hard time discerning being concerned about initiating intimacy that's not going to be successful for them, and lack of libido. So I think that may be hard in terms of parsing out which part of that is what. Certainly from a medical perspective, I encourage a lot of my patients who find libido issues to be a challenge to investigate testosterone levels, because we do know that that plays a component in both erections and sexual health or sexual drive. And I would also say that sometimes when we do support a patient, whether it's with a low dose daily Cialis or non-demand medication to support their erections, if they're able to sort of take it for a test drive and understand that they are going to be successful, confidence can grow, and then therefore libido can follow. So it is, I agree with Mark, difficult to discern which one's leading the path. By the time they get to me, most of the time it's the erections that are really a consequence of causing problems, with their libido. But we do investigate them separately in my practice and work toward aiming to increase both the libido and the erectile function to give a guy back a feeling of overall sexual health and well-being.
All right, final question here. Viagra and injecting are giving me so-so results. I'm a diabetic and I'm hesitant to go the implant route. What is my best route of option?
Sometimes you just have to combine things, you know, and adding a pump into the mix, trying the intraurethral injection therapies. A lot of patients, unfortunately, fall prey to some of the men's health clinics that encourage revascularization through modalities like ultrasound or shockwave, which really aren't there in the mainstream yet, and unfortunately are expensive and unlikely to be successful, especially with diabetic patients. There are no true revascular procedures to allow for clearing out the vessels to allow more blood flow to the penis. I completely understand a patient's reluctance to go down the implant route. And what I would encourage is I have a patient champion who's a patient of mine who received a penile implant and an incontinence procedure. And he didn't know about it and didn't go through it for a very long time, but now it's been pretty transformative to him. So perhaps this patient might want to inquire with his local prosthetic urologist about someone who's been through the process. So maybe he might get better insight with what going through a penile implant truly is like, because I think in the end, that's ultimately the best choice for this type of patient.
All right, and that wraps it up. So with that, I'd like to thank Dr. Heller and Mark for taking the time to present today. And we'd also like to thank everyone listening in for attending this MinMD Real Talk webinar. We hope that it was informative and that you'll join us again in the future. If you'd like to learn more, you have a few options. There are more resources in the Resource Center on minmd.com. You can visit this page to view instructional videos, guides, expert articles, and much more. You can also call MinMD at 857-233-5837 or log into the password-protected secure MinMD portal to schedule an appointment with one of our MinMD clinical case managers. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.org. We'll also be sending a follow-up email with references to helpful resources and links to each after the event. I'd like to thank everyone again for attending today's webinar, and we'll see you at the next one.